Hi, thanks for joining. I'm coming to you from the first annual APAPP Conference, a conference for PAs and NPs in the pulmonary world. And this is our first annual conference, and it's in Las Vegas. It's been a great success. And my name is Brian Bezic. I work in pulmonary medicine in Boise, Idaho, in that area, and enjoy very much treating asthma and difficult to treat asthma. And that's what we're going to talk about today. So I'm going to turn it over to my co-host, Amanda, and she's going to get us rolling.
Thanks, Brian. Hi, everyone. I'm Amanda Michaud. I'm a PA practicing in allergy and immunology in Jacksonville, Florida. I love allergies and asthma and excited to be here at this first meeting. So thanks for having us. So we'll just dive in. We're just going to kind of talk about biologics and asthma. And, the first thing that always comes to mind is really what kind of patient we're thinking needs to be on a biologic, right? So like when you're seeing patients in practice, what stands out really? And, as far as what a patient looks like that typically ends up on a biologic.
Yeah, and that's a great question because a lot of patients come in with asthma and they're pretty well controlled or we're doing well. And then there's that whole other group and you see their name on your schedule and you're like, oh, I hope they're doing better. And they come in and they say, they're just not doing well. Maybe they had an exacerbation. Maybe they're struggling a little bit. So at that point you think, okay, what's my next best step? Have I maximized their inhalers? Have I done what I need to do with that? Is there other things? Are they using it correctly? But at some point you get to that line in the sand, you say, I think that this is a patient that may do well with advanced therapy. Is that kind of where you're at too? Or?
Yeah, absolutely. You have that patient that comes in, right? Thankfully, a lot of our patients are well controlled, but then you have those patients that are going to see us in the pulmonary and asthma specialty office that aren't controlled, and you just put them on triple therapy. They come back for follow-up and they're not any better. They still had 2 more rounds of oral steroids, went to the urgent care twice since last time we met. And those patients really, they're the ones that we think about. Obviously, just like you alluded to, checking inhaler technique, making sure they have the right inspiratory flow to use that right inhaler, making sure we're treating comorbidities. But then, those patients that have severe asthma, the next step is to think about, well, how do I figure out what biologic to put them on? And that's where we can use biomarkers and do what Gina says is a phenotype assessment. And that really means check the biomarkers, right? So how do you usually handle that discussion, I guess, with your patients in practice?
Well, at that point, if I have my way and I can do whatever I want and things are perfect and patients always show up, which doesn't happen not. But if that's the case, then I like to broach that subject. And so maybe I'm going to step them up in therapy, but I will try to introduce the idea of, hey, we have therapies now. And I have a little poster usually behind me. And I say, we have these therapies that are really different and they can be life-changing and they're wonderful, very safe. And this might be a direction we're going to go. And so I'll introduce that. I do have a couple of literature things that I hand out. If I can do that, then the next visit, a lot of times they're already kind of becoming contemplators maybe, and I've introduced it or they've looked it up at home. And so at that point, then I can kind of dive into it a little more, especially if I already have lab tests. Do you get blood tests? I mean, if you're seeing somebody consult the first time, are you getting any of these biomarkers initially?
I feel like, it's hit or miss. Sometimes, they've had really good care and they're referred to us because their primary care doctor or maybe another community pulmonologist that perhaps doesn't use biologics in their practice sends them to us. And we already know, they need to be on a biologic just based on their kind of clinical course and the way the conversation goes. And it might have been mentioned to them earlier, right? And then I'll get those labs right away and pheno and spirometry in the office. Do you do pheno in practice? I know a lot of offices can't do it because of restrictions and insurance coverage, but we're pretty lucky where I'm at that we do it on almost every asthma patient. I don't know how much you're using it.
So I have access to pheno and spirometry, thankfully, because then it's a lot less expensive for our patients if I can do it in-house. Full on PFTs, I have to send those out. And I do get those sometimes on asthma patients, not quite as often as I do with COPD. But yeah, and so if those are done, then I have this data in front of me. I have some of these biomarkers. Maybe I know their total serum eosinophils. Maybe I know their IgE. I get a really good history. And if I have pheno, that builds that picture. Mm-hmm. Combine that with how have you been? What are your exacerbations? What do you want to do? What are you doing in your life? Are you not doing certain things with exercise or activities? And then that puzzle kind of gets clearer and clearer as they're talking. And you realize, this is somebody that really, if we could improve their exacerbation rate, improve their symptoms, their quality of life, it would have a big impact.
Yeah. Yeah, I'll usually, take those patients at whether it's the first, second, third visit that we know are going on that route to a biologic. Like you kind of mentioned, I'll mention it. I'll often give the lab order, so they have it and they'll kind of think about it. They'll chew on it for a while. A lot of patients are very motivated, right, to start, and then some just want to kind of think about it a little bit more and see how they do. But I'll usually give them the lab slip so that they have the availability to go to the lab, get it done. We don't have a lab in-house. So they'll get it drawn. And then when I see those labs come back in, usually that's my indicator that, all right, this patient has already kind of decided, maybe they don't want to start yet, but they've decided they want to explore this as well. And, because we have so many options now, it's really hard. Back in the day, we used to just be able to talk about omalizumab at that visit right away. Now we have so many different options. So I don't like to get into the treatment that I would choose yet until I see those biomarkers, right? Because that really influences treatment so much,
Yeah. And I think having long conversations about medications or disease states they don't have is just not valuable and it's not helpful. So you're right. I think when you get to the point where you're thinking, and if you've kind of already come up with what might be best in your mind, then that's when you can approach that. I love the idea of having them kind of participate a little bit. And now they've gone in and done the labs. They're invested in this, which that's great.
They made that first step. Yeah.
That's buy-in
huge.
already. Yeah.
That shows you, that they're thinking, okay, this provider told me that there's other things we can do. Let's kind of check this out. And so, and then they'll come back for follow-up, right? And we'll have the labs right there to talk about. And then, maybe repeat Spiro or Pheno, depending what we did the previous visit. And then have a discussion about, and sometimes it's very easy, right? Where they fall in the category perfectly where we know what biologic to give them. And other times it's like, well, all three of these might help you, but choosing which one's best is something that we try to do. We want to get it right the first time, right? So, when we think about the different biologic options that are out there, now we have one that's very broad, right? That treats non-Th2 and Th2 asthma. But I really try to educate other colleagues and kind of share the idea of that we want to target the pathway as specifically as we can rather than broad coverage. But that broad coverage agent, the tezepelumab, is still great for so many patients, especially those with like non-Th2 or non-specific triggers, right, that aren't good on another biologic. So I think it's really important to use those biomarkers, but also think of their comorbidities, right? Like what our patients also usually have with their asthma, right?
Yeah, find out. I mean, if they have allergic rhinitis and maybe they have polyps, maybe they've got eczema or have had eczema issues, they've got these other things, and we have dupilumab, which has multiple indications and bigger bang for the buck. And also, I like if it gives me other options. If their asthma maybe isn't the thing, I think I can get it approved. We have other options for approval in that right patient.
Yeah. So, when we think about like how to choose, so obviously you mentioned like the eczema patient, the polyp patient, we have numerous different options, but what are some of the things that you look at with biomarkers that help you make that decision?
Well, that's a big part of it. And, and thankfully I think you can see IgE and see if that's significantly elevated and check that box. And if eosinophils are significantly elevated, you can check that box. If Pheno, also how well they've responded in the past to steroids. If they, when you went on prednisone, what happened? Oh, it was the most amazing thing. I ran a marathon, or they just, they didn't. And family history, if there's no atopic family history and they don't have a big atopic history, so you can go down a different path. So usually it's pretty helpful. But I will also say that there's a lot of bias with me because I like the term infrastructure. We have the infrastructure really well to do a couple of these biologics at my office just because we know how to get them approved. We have the paperwork, the nursing staff is familiar. And so it is easier for those when you have that. And I would just encourage people, if you don't have that infrastructure in place and you haven't done it, maybe pick one or two that you can be really comfortable with. And if you do that, maybe you do dupilumab or you do, one that targets TSLP, or you're doing it a little bit differently. But you have those that you can get really comfortable with and good at, and that will then facilitate other biologics as they come out.
Yeah. And then, you look at the criteria and the indications, right? And it tells us exactly really what we need to get these patients on. Like they need to have this level eosinophil count or whatnot. But having someone in the office, everywhere I've worked in 3 different allergy asthma clinics now in my career. And we've had a biologics coordinator at every single location that I could just tell them, hey, this patient's note is complete. She's a candidate for this. Here's her eosinophils. Here's her pheno. Go ahead and submit everything. And we really don't encounter a lot of issues, thankfully, because we've already have our ducks in a row. I think it's important to like really think about too, yes, you could have elevated IgE, you can have allergy, but does that person really have that, like you mentioned, atopic background, atopic family history? Is this really early onset asthma? And are those allergens relevant, right? Like you can have sensitization to like one mold and dog, but never be really exposed to those things enough to at least explain your symptoms. And so that patient may not be the best candidate for anti-IgE, even though their labs suggest they could be. That might be a dupilumab patient, right? Yeah. And I think about finding the right fit, because this can be a big buy-in from patients, right? And we want to get it right the first time. We want them to have trust that we're putting them on the right biologic. And I think that's why we always strive to talk so much about the biomarkers, right? I mean, I scream about the biomarkers all the time when I talk about asthma. What about with COPD though? Because that's another big area of research. So I know I don't really treat COPD in my practice, but you do. So what do you think there?
And so we don't have anything approved yet, but the exciting thing is that there are medications that may be approved, dupilumab specifically this year at some point, kind of expect that. And tezepelumab is in the end kind of part of stage 2 going into stage 3. So that's going to be a while. But the exciting thing is if patients have some of these Th2 inflammation features, and maybe they have elevated eosinophils over 150, but for sure over 300, at that point, they may benefit by suppression of that part of their immune system. You suppress that, even though their main diagnosis is COPD, and it could help. And the data, I think, is very good. In fact, I think it would really mimic what happens when you go from a double inhaler to a triple inhaler. And that kind of step up in control is what happens with that. That's what it looks like anyway with the biologics. So once those get approved, it'll be an exciting addition for those patients that have some of this inflammation.
Yeah, that's going to be huge. I think about, the classic patient that we see, right? They come in, they're on, most of them, maybe on triple therapy already perhaps. And we have that talk with them about the ways that we can assess which fit is best. And I like to word it like that, hey, there's, 5 or 6 different options now. We can do labs to find out which fits you best. And then we can specifically talk about that drug and that agent and the ins and outs, because even though we're really comfortable with these, it's a big step for patients, right?
It's a big step.
And we want to be clear, like a lot of people think injectable medicines, okay, immune suppression and all these other risk factors for other things like the other kind of rheumatoid injectable, medicines that can modify the immune system. And we're able to say, well, we don't really see suppression per se. But I think, having that initial talk about that safety at least, and we're really comfortable with how safe they are, but it takes a lot for a patient to kind of make that decision. It's a big step.
Yeah, it is. And it's the word biologic can be scary. I think some of the newer medicines for weight loss, I think they've kind of helped a little bit, because even though that has nothing to do with what we do, the comfort level with injecting medications is higher, but it's still huge. Like, and the fear, we just started a patient last week on dupilumab, and he was kind of a tough farmer guy, but anyway, doing the medicine, there was some sweat and it was a scary thing. Man. And afterwards, he's like, okay, I got this. And I like, well, just imagine your life without these flare-ups that you've been having. And he's like, okay. And I say, so it's going to be worth it. And after a couple of times, there's usually not very much stress, but it's a scary thing. And if patients are open to it and you can really talk about the safety profile, this is so specific to this inflammation, the kind that you're having that's driving a lot of your symptoms, and it isn't going to decrease your ability for immune surveillance for viral infections or bacterial. And we've got plenty of data to support that. This is not new. None of this data is new. And you've had Xolair for 20 years or 21 years. So we've got very good data that this is specific. So the safety, good, the overcoming that initial hurdle, once you get there, usually there's a lot of patient satisfaction.
Yes, absolutely. And I think that, I usually give that expectation, we see these awesome results in these studies, but research settings aren't always real worlds, right? Even though it typically is very similar to what we see, but in reality, I think a lot of our asthma patients are more heterogeneous than what we really see in these research studies, where they're able to really rule out all these other comorbidities, right? And just see this pure patient that will have this amazing super response to Xolair or Dupixent or Nucala, Fasenra, whatever we decide to use. But in the real world, we have patients that also have other like non-specific triggers. They live with a smoker, or, they're exposed to fumes and odors and other kind of occupational things, whatever that might set them off, or air pollution, whatnot, or maybe even a touch of COPD, right?
Yeah.
And so, I think that it's important, when we look at that data, I like to tell patients like, hey, this is the standard patient. Not everyone, follows this perfectly. Based on your labs, I think you would fit this agent best, have the most successful potential outcome. But if not, after 4 months, they say 4 to 6 months, right? I usually wait 4 months. And at 4 months, I might start to have that discussion about, well, maybe we switch. And then, I never go longer than 6 months. What about you? Do you?
Yeah. Usually and it depends a little bit what time of year it is, because if it's September and they went back to school, maybe I'll postpone. I'll say, okay, we had we had these viral flares that come with when you return to school. So part of that, but at 4 months, if they are feeling like, hey, this is not worth it to me, I'm more than happy to either, if I think there's going to be a good response, I may push it longer, but I really want to know what they think, because it's just like atopic dermatitis. If the itch is better, the patients are so willing to do whatever. And if in this case, if they really feel like, hey, I'm breathing better, or whatever comorbid conditions are better, at that point, then if they're not happy and they're not seeing that, then I'm happy to stop. But I don't go past 6 months.
Yeah, rarely. And even after 4, it's like a circumstance like you described, like they went back to school, or there was a lot of times patients can give us a very specific, like, oh, well, I went up in the mountains and there was a wildfire or something like that, where then we're thinking, okay, maybe it's not really, the medicine's not working. There was just this huge extra trigger for you, and we'll give it some more time. But yeah, beyond 6 months, it's really not worth it. And then, we can go back and look at those biomarkers again and the comorbidities, right? Like if someone's not responding like we expect, I'm always thinking about what else could this be. I'll recheck biomarkers, especially if I was very confident in there. I can usually tell by the way I document in a note.
This should have worked.
Yes.
This should have worked. Yeah.
Yes. And I can usually tell by the way I document in a note, because I'll write out my thinking, because it helps me for the future if they don't get better. Now, thankfully, most of the time we get it right because we check biomarkers.
Yes.
So most of the time we do get it right. But there's still going to be those patients that have other structural issues with the lungs, or, fixed airway obstruction potentially, or just other stuff that's influencing their treatment. But, I think about, when I think about like the classic, which drug goes with the classic patient, of course, I think of the early onset asthmatic that has high IgE, lots of allergy, or like the adult with like 5 cats that's allergic to their cats, right? They get on Xolair. I mean, that's easy.
Cat equals Xolair.
I mean, it's just, it's always the cat. It's always the cat, guys. It's always the cat. And they're family members. They're not going to get rid of them. But then, then I think of the patient that has really high EOs, late onset, right? And, maybe if they were really high, really other things, but they're classic IL-5. And we're not really using Resolizumab IV that much because we have the other ones that are great. But then I think about, the patient that's like mixed, like the ones that meet kind of all the criteria, but also if they have high FeNO, they do best on dupilumab. But then there's the patient that's like, okay, either was on a biologic, had a partial response, and then you realize when you're talking to them, okay, there's a lot of other like things going on here, illnesses, viruses, things like that. They may be a good candidate for anti-TSLP. And of course, like the patients that we get that don't have evidence of any biomarkers, and that's kind of like my general train of thought. A lot of people ask me, like, what would you do? Because I think for a long time, everyone's just we had Xolair and that was it.
Yeah, that was it. Right.
And it didn't work for everybody. It works for a lot of other things, but didn't work for everybody with asthma. And then I think that's where the biggest confusion is, when it's someone in the middle and you kind of have to look at the whole picture. And that's where, they're still going to get better no matter what we do. They're going to get better on anti-IL-5 versus anti-IL-4/13 versus TSLP. It's just finding the best one. Because what I also don't like is if they get better, but they're not like really a lot better.
Not way better, yeah.
Like they're 40% better, which is huge for them, but they're not, they're not where I want them to say, like, I'm doing all these things now, and the biggest thing is that these patients are so limited, right? Especially with late onset asthma, it's more of that kind of constant persistent disease where they're symptomatic no matter what they do, checking their mail, walking to the end of the hallway at their house and stuff. But if I don't hear that after 4 months, they're like, oh, this stuff is a game changer, we got to think about what else could be going on.
You want them to say, this is so great. And I was on the trials for one of them, the approval way back when, a lot of years ago. And they did. A lot of the patients that it was blinded, but still you could kind of tell because they were saying this This was so great. So yeah,
I
you
know.
want that. And I do think if you take some time and try to be as specific as you can and try to dive down as much as you can with these patients and get the most likely benefit. If you pick the second best, you're probably still going to be fine.
Yeah.
So I wouldn't over worry about it. But if you can drill down a little bit and look at those biomarkers and get a cheat sheet out, that's okay. Get out a cheat sheet if you need it. But just do it. If that's the right patient, you've confirmed the diagnosis and you can get them on it, I would really encourage you to try in those patients with severe asthma, especially with those with lots of exacerbations, because they can imagine their life without those and they would like that. And so give it a try if you can. Yeah. Anything else? What would wrap up? Any words of encouragement to people who maybe haven't tried biologics?
I think the biggest thing is that now that we have multiple, I think there's even more education on like algorithms to follow based on patients' biomarkers. And I follow this immune cascade in my mind every single day with every patient I see. And I'm in a very academic practice where we're kind of expected to know the whole cascade and inflammatory cycle and all of that. But a lot of practitioners don't have comfortability with that. I think the biggest thing is don't be afraid to go back at that picture or have a chart or an algorithm that you follow. Okay. And there are lots out there, okay, here's this patient. They have this, they have allergies, they have that. There's so many tools out there now, decision tools that can help with your aid in that. And then you can also feel more confident when you choose things. So I think look for the UpToDate has a really good one. That's really up to date. It has Tezzy on there now too. So I think that's the best one. And I think we include it in our slide deck that we're doing later too.
Yeah. So don't hesitate to get those helpers and those things that can walk you through it. And you'll get comfortable if you do that.
Yes.
Yeah.
And no patient, especially if you plant the seed and that gives you time to kind of think about what you want to put the patient on when you get the labs back. No patient's even going to expect you to know right then and there, but it'll give you that confidence once you kind of looked at that algorithm and tell that patient, hey, based on what I'm seeing, this is going to be best. And I think that's the biggest thing. There's no shame in needing to look at a textbook or a journal.
End with be brave and get help and no shame. And that'll be that's our mantra for today's podcast.
Yes.
All right. Thanks everybody.
Thanks.